Welcome back to the deep dive. Today, we're jumping into a topic that is just so critical for anyone in nursing, muscle relaxants.
It really is.
We're working from a really comprehensive chapter in a nursing pharmacology text, and our mission here is precision. We want to get the mechanisms, the uses, and I think most importantly, the safety checks exactly right.
Yeah, that's the goal, because these are really powerful agents. They affect things we take for granted, movement, balance. So our goal for you is a shortcut, really, to understanding the two main drug categories and what to watch out for.
Okay, so let's unpack this.
Uh-huh.
I think we have to start by defining our targets.
Absolutely.
We need a really crisp distinction between muscle spasm and muscle spasticity. They sound similar, but they're completely different problems physiologically.
And that difference is the cornerstone of how we treat them. Muscle spasm is usually acute. Think painful involuntary contractions from, say, a sudden injury.
Like you overstretch something at the gym?
Exactly, or you wrench a joint. What happens is the injury triggers this vicious cycle. Sensory impulses flood the spinal cord, the muscle seizes up.
And that contraction cuts off its own blood flow, right?
Right, which creates pain, lactic acid, and that just triggers more contraction. It's this horrible acute feedback loop.
It's like the body is trying to protect itself, but just ends up making everything worse.
Yeah.
So if that's a spasm, what's spasticity?
Spasticity is a permanent condition. It's chronic. It's from damage to the neurons inside the central nervous system itself, so in the brain or the spinal cord.
Okay.
You see this in things like cerebral palsy, MS, paraplegia. The nerve signals are just permanently messed up, leading to these sustained contractions, what we call hypertonia. It's a whole different ballgame.
So before we get into the drugs for those two things, we should probably do a quick review of the body's, the infrastructure for movement.
Yes, because the drugs target different levels of this exact system.
So how does it all work?
Well, every single movement, every posture change, it's all coordinated by our spinal motor neurons. And they're getting their orders from higher up. The cerebellum is for your conscious, skilled movements.
Like picking up a pen.
Exactly. And then the basal ganglia handles the unconscious stuff, the automatic adjustments that keep you balanced.
So what's the most basic pathway? The simplest one.
That would be the spinal reflexes. You might hear it called the gamma loop system. It's a simple direct arc. A sensor in the muscle feels a stretch and bam! The reflex causes a contraction to correct it. It's the body's autopilot for just maintaining muscle tone.
And then the brain's input layers on top of that.
Right. Through two main tracts. You have the pyramidal tract. I always think P for precise. It controls your intentional fine motor movements.
Typing, threading a needle, that kind of thing.
Perfect. And then you have the extrapyramidal tract, which is for everything you don't think about. Posture, balance while you're walking, all the unconscious coordination.
Okay, that all matters because different drugs are going to interfere at different points here. Let's start with the ones that target that first problem we talked about, the spasm. The centrally acting skeletal muscle relaxants.
Or spasmolytics.
Spasmolytics, I like that.
Yeah.
Lysis of the spasm.
It's exactly what they do. And they work exclusively in the CNS, in the brain and spinal cord, to basically interrupt those overexcited reflex arcs causing the spasm.
What's really interesting to me is that even within this one class, the mechanisms aren't all the same.
No, they're not. I mean, most of them just act as general CNS depressants, which is why they work. But then you've got an outlier like tizanidine, which is an alpha-adrenergic agonist. It's a totally different pathway.
But the therapeutic goal is the same.
The goal is the same, and this is key. They are adjuncts. They should never be the only treatment. You need rest, physical therapy, ice, heat, NSAIDs, the whole package.
And it's funny that diazepam, Valium, shows up in this category.
It makes perfect sense, though. It's a powerful CNS depressant. If a patient's anxiety is actually feeding into that spasm cycle, which it often does, diazepam can be incredibly effective at just breaking the whole loop.
Okay, so that's for acute spasm. What if we're dealing with the chronic stuff, the spasticity? What's the go-to prototype in this central category?
That would have to be Baclofen. Brand name, Leorasol. Its action is very specific. It's a GABA analog, and it works to inhibit those spinal reflexes.
So it's a mainstay for spasticity.
A critical one. For the most severe cases, like with spinal cord injuries, it can even be given intrathecally, so directly into the spinal fluid with a pump.
Okay, now we have to get into the safety warnings because this is a big one.
Oh.
What is the absolute #1 contraindication for Baclofen?
You cannot, I repeat, cannot use Baclofen to treat spasticity that a patient is actually using for functional movement.
What do you mean by that?
I mean, if that rigid muscle tone, that spasticity, is the only thing allowing them to stand upright or to walk.
Oh, I see.
If you block it with baclofen, you cause a total loss of function. You're basically trading that rigidity for a complete collapse. It's a critical distinction to make.
You'd be pulling the rug out from under them, functionally speaking. So beyond that huge warning, what are the common side effects?
Mostly what you'd expect from a CNS depressant. Drowsiness, fatigue, confusion, some GI stuff like nausea or dry mouth. But the most important point is about stopping the drug.
No good.
You cannot stop baclofen abruptly. It has to be tapered, slowly, over 1 to 2 weeks. If you don't, you risk severe withdrawal, psychoses, and hallucinations.
Psychoses and hallucinations.
Yeah.
From stopping a muscle relaxant.
Yes. It just highlights how powerful these central effects are. Patient education on this is not just a nice to do, it's a life-saving intervention.
Absolutely. And on a lighter note, is there that one about the urine color?
Oh, yes. A great little fun fact to tell your patient. If they're on chlorzoxazone, you have to warn them their urine might turn a very alarming orange to purplish red.
So they don't panic.
Exactly. It's totally harmless, but you can imagine the fear if you weren't expecting it.
Okay, let's pivot to the second major class of drugs, which to me is even more fascinating. The direct-acting skeletal muscle relaxants.
Yes, this is where it gets really interesting, because
Yeah.
these drugs, they don't even touch the CNS. They go right to the source, straight into the muscle fiber.
The prototype here is Dantrolene. So how does it stop a contraction if it's not messing with the brain or the nerves?
Dantrolene's mechanism is just so elegant. It acts inside the muscle fiber, and it interferes with the release of calcium. Calcium is the on switch for muscle contraction.
Right.
By blocking its release from its storage unit, the sarcoplasmic reticulum, dantrolene just prevents the muscle from contracting at all. It doesn't matter what signal the nerve is sending.
That's incredibly powerful. So what are its main uses?
Well, it's used for chronic spasticity, like baclofen, just with a different mechanism. But its other use is absolutely life-saving. It is the primary drug for treating malignant hyperthermia.
That's the rare, deadly reaction to anesthesia, right?
Yes, that rapid spike in temperature, severe muscle rigidity. Dantrolene's ability to just shut down muscle contraction at the source makes it the only thing that works in that emergency.
Okay, and this category also includes the famous, or maybe infamous, neurotoxins.
The botulinum toxins,
Yeah.
yes. Botox, Xeomin, myoblock, and they're not just for wrinkles anymore.
Not by a long shot.
No, I mean, these are powerful toxins that work by blocking the release of acetylcholine right at the nerve terminal. Acetylcholine is what tells the muscle to contract, so if you block it, you get local paralysis.
And that local effect is key.
It is. It lets you treat very specific muscle groups for things like severe cervical dystonia, that's where the neck muscles contract and twist the head, or chronic migraines, even severe underarm sweating.
But despite how common it's become, we have to talk about the FDA black box warning on these. This is critical.
It cannot be overstated. The warning is there because there's a risk that the toxin can spread from where it was injected to distant parts of the body.
And if that happens,
You can get symptoms of systemic botulism, difficulty breathing, difficulty swallowing. It can be life-threatening. It's why technique and medical supervision are everything.
which brings us right into our big nursing considerations. What does all this mean for patient care across different age groups?
Well, starting with kids, the safety for most of these drugs just hasn't been established. There are a few exceptions, like Baclofen for cerebral palsy or methocarbamol for tetanus. But botulinum toxins are generally a no-go for children because of that higher botulism risk.
And for adults, it seems like the common thread is always CNS depression.
Always. You have to hammer home the point about not driving or using heavy machinery. They're going to be drowsy and potentially dizzy. And for women of childbearing age, contraception counseling is a must because we just don't know enough about the effects during pregnancy.
What about older adults?
They're at a much higher risk for all the adverse effects, CNS, GI, cardiovascular, just because of the potential changes in liver and kidney function as we age. Interestingly, carisoprodol is often the preferred centrally acting drug for this group because it tends to have a slightly better safety profile.
Let's dedicate a specific moment here to the most severe risk we've discussed, the hepatotoxicity with dantrolene. It's not common, but it's fatal when it happens.
And that's why we have to be so vigilant. Dantrolene is specifically linked to potentially fatal liver injury. The risk is much higher in two specific groups, women and any patient over the age of 35.
And there's a drug interaction that makes it even riskier.
Yes. Combining dantrolene with estrogen from birth control, hormone replacement, whatever, it dramatically increases the risk of liver damage. That combination should be avoided, if at all possible.
So how do we catch it early? What do we tell patients to look out for?
We teach them about what's called the prodrome warning syndrome. They need to report any anorexia, nausea that won't go away, or just unusual fatigue. Those can be the first signs. And of course, liver function tests, LFTs, are mandatory. They're not optional.
So if we were to summarize the absolute must-do nursing actions for these drugs, what would they be?
Okay, three things. First, for dantrolene, you discontinue it at the very first sign of liver dysfunction. Know your baseline LFTs. Second, for botulinum toxins, never inject into an area with an active infection. And third, for all of them, monitor relentlessly for increased CNS depression when they're combined with anything else that's a depressant, especially alcohol or opioids. That combination can kill.
This has been a really, really insightful dive. So we basically have two very different classes of drugs here, the centrally acting ones, the spasmolytics.
Right, they work in the CNS to treat acute spasm.
And then the direct-acting ones, like Dantrolene and Botox, which work right at the muscle fiber to treat chronic spasticity.
And the main lesson, no matter the drug, is always safety. Managing the CNS effects, watching for withdrawal with Baclofen, and that critical liver monitoring for dantrolene.
So as a final thought for you to chew on as you study this, we talked about how powerful these botulinum toxins are. I mean, they're neurotoxins with a black box warning.
Literally paralyzing muscle.
Yet we use them for really serious medical conditions like chronic migraines, but also for cosmetic procedures, even things like Botox parties. So the question to ask yourself is this: what really separates those two uses? What makes one a controlled medical procedure and the other a huge risk? And why is holding that line the absolute non-negotiable duty of a healthcare provider?
The power of the drug demands the expertise of the provider. That's really it.
An excellent way to put it. Thank you for joining us for this deep dive. We'll see you next time.